Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting spine imaging case. So as always, I'd like to start out by saying that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So the history in this case is a patient who came in with chronic neck pain. This had been a very long-standing problem for them. And we've got three images to look at. The image on the left is a sagittal non-contrast CT in bone algorithm. Image in the middle is that same slice of the sagittal non-contrast CT, only this time in soft tissue reconstruction. And then the image on the right is a sagittal T2 weighted image. And while you look at take a look at the findings, I would like to take just a moment to thank Dr. Bob Choplin here at IU, who was kind enough to share the images with me for this case. Okay, I've got a bunch of questions for you this time. First of all, what are the findings? Second, does this patient have normal or abnormal craniometrics? Third, what's your differential diagnosis? And lastly, based upon what you're seeing here, what's your most likely diagnosis? Okay, so let's take a look at all the images. First up, we have our sagittal non-contrast CT, again in bone algorithm reconstruction. And what you can see here is that C1 and C2 are normally aligned with respect to the skull base. So if we take our basion opistheon or our McRae line, you can see that the dens stays below it, so we don't have any cranial settling. So in this case, we have normal craniometrics. If you look carefully, you'll see that there's a large degenerative or subchondral cyst that sits at the posterior margin of the upper dens, denoted here by the yellow arrow. And that's a clue that can help key you in on what this might be. And then you'll also see that we have partially calcified retrodental soft tissue, denoted here by the yellow arrow. When you look at the bone algorithm, you can see it's not coarsely calcified, but there is some fine linear calcification to it. So again, looking at our sagittal CT, this time in soft tissue reconstruction, we can again see the large partially calcified retrodental soft tissue, denoted here by the yellow arrow. And whenever we're dealing with something that's non-rheumatoid, in this case is not, this is oftentimes referred to as pseudopannus. It's not true rheumatoid pannus. But importantly, you can see this is causing severe thecal sac stenosis, denoted here by the yellow arrow. And in fact, it's causing pretty significant cord compression. You can see that cord is being absolutely smashed by this large retrodental soft tissue pseudopannus. And as we look on our T2 weighted image, again we see that large retrodental soft tissue pseudopannus, and it has pretty heterogeneous signal, but for the most part, it's very T2 dark. We can also see that degenerative cyst that's sitting at the tip of the dens posteriorly. Again, that's a clue as to what might be going on here. And obviously on MRI, we see this severe thecal sac stenosis and cord compromise much better than we do on the CT. So, put it all together, what's your most likely diagnosis here? So this was a patient with calcium pyrophosphate dihydrate crystal deposition disease, or CPPD, and this is a arthropathy that's due to the deposition of calcium pyrophosphate dihydrate crystals into the joints and surrounding soft tissue. So this is one of our crystalline arthropathies. And it's important to keep in mind that atlantoaxial CPPD is extremely common. It's estimated that it's present in about a third of patients over the age of 60, and by the time you hit age 80, it can be found in about 50% of patients. And really the hallmark imaging findings to keep in mind are chondrocalcinosis, as well as the commonly associated subchondral cysts, oftentimes in a so-called string of pearls configuration. But unfortunately, this is one of those cases in radiology that ticks and fleas can coexist. So you can see patients who have CPPD and in addition other crystalline arthropathies such as gout or hydroxyapatite deposition. You can also see CPPD coexist with rheumatoid arthritis on occasion. And importantly, because of the inflammatory response and the hyperemia, you can also see CPPD in the setting of discitis, because as the old saying goes, bugs go where the blood goes. If you have a chronically inflamed area in the body, it's hyperemic, it has more blood being delivered to it. If patients are transiently septic, the bugs can go where the blood goes. So what are some of the common CPPD spine manifestations? We'll be on the lookout for those subchondral or degenerative cysts. It's oftentimes associated with vertebral end-plate and odontoid erosions, and those erosions can even set you up for fractures of the dens. You may see intradiscal calcification. This is something that probably gets called CPPD, more common than it is, but certainly you can see it in the setting of CPPD. You'll also see facet disease with facet joint effusions and erosions. And then look for that calcification. You may see calcification of the odontoid ligaments. That may be associated with erosions as well. There's a clinical scenario that's referred to as crown den syndrome, and these patients with CPPD can have episodic pain and stiffness at the craniocervical junction, and that's due to usually to the profound calcification of the transverse ligaments, as well as to some degree the degenerative pseudopannus that they have at this level as well, and that can be associated with C1 and C2 instability. One of the things to keep in mind, though, is that when you see that retrodental soft tissue pannus, or pseudopannus in this case, look for calcification. Rheumatoid arthritis is much less likely to have calcification than CPPD. So when you see the presence of calcium, be thinking CPPD over rheumatoid arthritis. Obviously, you'll need to look at other joints in the body, pull out the patient's jacket, see what other imaging they have to look for other telltale clues that can lead you one way or the other. So for further reading, there was a nice paper that was published a few years back in radiology, and this was just looking at the relative frequency of CPPD involving the atlantoaxial joint and just how common it is in older patients. So this is worth taking a look at. Okay, so let's wrap this up. This was a case of CPPD of the spine, and the key imaging features that you need to keep in mind are, first of all, be on the lookout for those subchondral or degenerative cysts. May be associated with vertebral end-plate and odontoid erosions, and that can even set you up for potential odontoid fractures. Be on the lookout for intradiscal calcification. This is something that can certainly be seen with CPPD, but the specificity is relatively low for making that diagnosis. Look for the facet disease, facet joint effusions and erosions, and then be on the lookout for calcification of the odontoid ligaments that may be associated with erosions. There are a couple pitfalls to keep in mind. First of all, if you see that calcified retrodental soft tissue, that's going to favor CPPD over rheumatoid arthritis, but don't forget that sometimes patients have ticks and fleas. In other words, they may have coexistent disease processes like CPPD and rheumatoid arthritis, or even CPPD and other crystalline arthropathies like gout and hydroxyapatite deposition. And then lastly, always be on the lookout for things that are potentially going to harm the patient. In this case, look out for those associated fractures and potential instability at the craniocervical junction. So as always, thanks for tuning in to IU Radiology Case of the Day. You can always follow along on Twitter at NAKuntz, and I would invite you to check out the complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.